Well, good afternoon, everyone, and welcome to Trust for America's Health's Age-Friendly Public Health Systems, or AFPHS, September training. We're happy that you're here to join us today to learn more about how the public health sector can support older adult health and well-being. My name is Megan Wolf, and I'm joined here today by three of my TFAH colleagues, Dr. Cron Phillips and Brandon Rivas and Molly Warren, who you'll hear a little bit about more about later in the presentation. The AFPHS movement would not be possible without the generous support from and partnership with the John A. Hartford Foundation. And so we're thrilled to have our program officer, Jane Carmody, with us here today as well. Let's go to the next slide. Just a couple of logistics. If you all will please keep your devices muted during the presentations so we can avoid any background noise, but please feel free to put any questions you may have in the chat throughout today's session. And we do hope we'll have some time for some Q&A at the end. So next slide, please. Your feedback is really invaluable to us. We request that you all please take a few moments after the session today to complete this anonymous feedback survey that will appear on your screen. Your insights and responses will be shared with our evaluation partner at the New York Academy of Medicine and will really help us to enhance future trainings. And as we're preparing for our theme and training for next year, particularly, really appreciate your feedback. Next slide, please. So as most of you know, and I recognize a lot of the names on here today that you all are already familiar with TFAH, but in case there is anyone new, TFAH is a public health policy research and advocacy organization dedicated to optimal health for every person and individual. TFAH produces several reports annually, including our Ready or Not report, which focuses on emergency preparedness, and Pain in the Nation, which you're going to learn a lot about today. Related to healthy aging, we've produced some reports on several topics, including housing and rural healthy aging. And the front of the report you see here on the screen is our most recent one, which is on aligning the 10 essential public health services with our AFPHS 6 Cs framework to support healthy aging. So really commend all of TFAH's reports to you. I hope that you all find them valuable. So we'll go to the next slide and I will stop here. And oh no, I have one more, sorry. So this year, our monthly trainings have focused on health equity, which is at the center of our AFPHS 6 Cs framework and really central to supporting all older adults. So today our guest speakers are going to discuss some topics, some features from our Pain in the Nation report. We'll have some focus on equity and hopefully bring out some great recommendations around older adult health and well-being. So now I will turn the mic over to Karan to provide some additional context for our session today. So Karan.
So thank you, Megan. We thought it would be important to not only support the upcoming information being shared by our colleagues from the Pain in the Nation report, but just to give you some context and to ground ourselves a little bit more in older adult mental health, which is a definite growing concern. So 14% of the people that are 60 years and older live with some form of mental illness. So some common conditions being mood disorder, anxiety, or some form of severe cognitive impairment. 27.2% of deaths from suicide are among people aged 60 and older. Over 2 million people aged 65 and older suffer from depression. And 68% of people aged 65 and older know little or almost nothing about actual depression. Some additional context, nearly 1 million adults aged 65 and older live with a substance use disorder. An additional 10% actually binge drink. So there are some factors related to getting older that can increase the vulnerability of substance misuse. So older adults, metabolically, the substances they do that more slowly. Drug use can exacerbate some aging-related conditions, including memory loss, lung and heart problems, and mental health disorders. And older adults are more often to be exposed to addictive medications. And then just some final pieces. So risk factors for older adults relate to mental health and substance use. 80% of older adults suffer from at least one chronic health condition, which puts them at a higher risk of developing depression as a result of complications from these conditions. Ageism, we talk a lot about ageism in our trainings, and we start our trainings each year with an ageism training. Age-based discrimination and elder abuse can negatively affect older adults' mental health. Social isolation, so loneliness, social isolation, especially as a result of the pandemic, is common among older adults, and that can also exacerbate and increase mental health illnesses. And lastly, related to caregiving, many older adults are impacted by the stress of caring for a spouse with dementia or other chronic conditions. So with that grounding in rich context related to mental health, I'm going to turn the podium over to our two wonderful colleagues. We'll start with Molly Warren. She's a senior health policy researcher here and analyst here at Trust for America's Health. And then Brandon is going to provide us with some policy-related recommendations. He is our senior government relations manager as well here at TFAH. So happy to share the podium with our virtual podium with our colleagues today. And Molly, I'll turn it over to you.
Great, thanks so much, Karan. Good afternoon, everyone. Very happy to be here today. As Karan said, my name is Molly Warren. I'm a senior researcher here at TFAH, and one of my major areas of focus is working on our Pain in the Nation report series. So I'm just going to give a brief outline of what I'm going to discuss over the next 15 minutes or so you know where I'm going. So first off, I'm going to share some background about the Pain in the Nation report series. Then I'm going to spend most of my time talking about data and trends, including mortality trends for alcohol, drug, and suicide deaths over time, by different causes of death, and then by age group. And then I'm going to look a little deeper into the mortality data for the older adult population, and then further look at suicide among older adults, because the rates of suicide are extremely high in that population. So that is the plan. So let's get started. Karan, you want to move us along? Thank you. So again, the first Pain in the Nation report was released in 2017 with our inaugural 200-page report on the alcohol, drug, and suicide epidemics in the United States. Since then, we have released issue briefs focused on specific subjects, population, and data sets. And in the last few years, we have transitioned to longer annual reports with sections on the latest mortality data, a section on recommendations, as well as a feature section that changes each year to highlight a specific issue in greater depth. Our focus for these recent feature sections have been a bit more on drug overdose than alcohol and suicide, because the drug overdose rates have been escalating at such an alarming rate. I also want to note that we have a robust appendix that has all sorts of other data. So we have mortality data by demographic and geographic groups, including age group. We have substance use and mental health data, so indicators like illegal drug use, mental illness, again, by demographic group, and also by state. And then we also have state policies and programs indicators. So this is a dozen indicators like mental health access rankings, fentanyl test strip programs, 988 funding, safe gun storage laws by state. So if you're interested in knowing what your state is doing or can be doing, it's a really great resource. And so you can find all the reports over the years on TFAH's website, including our most recent report from July. Next slide, please. Okay, so now we're going to jump into some of the data and trends. Our reports focus a lot on mortality data, so deaths. It's also what I'm going to talk about mostly in this presentation, but there are many, many other ways these issues can harm individuals, families, and communities, in addition to the burden of mental health conditions or substance use. You can have non-fatal doses and suicide attempts. You can have substance-related car accidents and violence, higher rates of abuse and adverse childhood experiences, reduced productivity and economic consequences that can be, all these can be at individual, family, community, and really national levels. So we do focus on mortality partly because it's at the far end of the spectrum of harm, and also because the data available is comprehensive, it's national, it's updated regularly, it has fairly robust demographic information, and it goes back to 1999, so we can analyze time, demographic, and geographic trends. So with that background, we can actually look at the data and what's happening in the alcohol, drug, and suicide epidemic over the last 2 decades. You can see in the graph on the slide that the combined mortality rate, so that's the top blue line, has been rising consistently over the time period with very large increases over the last few years. There have been increases across all 3 causes of death over the last 2 decades. There's smaller but fairly steady increases for alcohol, which is the orange line, and suicide, which is the yellow line, and then the larger escalating increases in drug overdose deaths, which is the gray line. We know that drug overdose deaths have been primarily driven by synthetic opioids or fentanyl in the last decade. Overdoses from other drugs have also increased, but it's often because it's mixed. Those drugs are mixed with fentanyl. The illegal drug supply has become very dangerous with fentanyl added to many other kinds of drugs and people unknowingly ingesting and overdosing that way. On the more positive side, the most recent data shows some tentatively encouraging developments. In 2022, we actually saw a slightly lower mortality rate for the alcohol, drug, and suicide, the combined rate, compared with 2021. And this was driven by a 6% decrease in the rate of alcohol-induced deaths. And then we basically had unchanged rates for drug overdose and suicide deaths. And this is a really big divergence in trends compared with recent years. The previous 2 years have seen incredibly large increases. So if you just look at the last few years on this graph, you can see there's actually a tiny little dip. Next slide, please. Here we have another way of looking at the increases in alcohol, drug, and suicide mortality over the last 2 decades for the overall population. We went from a majority of states being in green in 2002, so that's under 30 deaths per 100,000, to a majority in yellow in 2012, which is 30 to 50 deaths per 100,000. And then in 2022, we have most states in the 2 orange categories, so 50 to 90 deaths per 100,000. And then there are some deaths that have topped 100 deaths per 100,000. And we had no states in the green anymore. So really just another way to look at some pretty catastrophic trends that have affected every state in the country. Next slide. Okay, so next I thought it'd be helpful to look at the mortality by age group. So in our report, we use 5 age groups. We have 0 to 17, 18 to 34, 35 to 54, 55 to 74, and ages 75 and older. The middle 2 age groups have the highest combined mortality rates. So from highest to lowest, we have 100 deaths per 100,000 for ages 35 to 54. We have 87.5 deaths per 100,000 for ages 55 to 74. We have 59.3 deaths per 100,000 for ages 18 to 34. And then we have 38.6 deaths per 100,000 for ages 75 and older. The older age groups have lower combined mortality rates due to the relatively low drug overdose rates compared to other age groups. So you can see in the left graph, the gray bars are the drug overdose rates and how they really change based on age group. But the combined age groups can obscure some other notable findings. So ages 55 to 74 have the highest alcohol-induced mortality rates of any age group. And then ages 75 and older have the highest suicide mortality rates of any age group. So it underscores the importance of looking at, the different causes and different ages, as well as other demographics. Next slide. So the next couple of slides focus on mortality data specifically for adults ages 75 and older. Here we have the time trends. So like this is like one of the first, a few slides ago. This is the same graph, but it's by different age groups. So we have the time trends for alcohol, drug, and suicide for older adults compared with the total population. And I separated out these three causes because there are quite distinct trends between the three compared with the overall populations. So you can see on the left that the alcohol is pretty similar to the overall population, while the drug overdose is completely different. Next slide. Since adults ages 75 and older have the highest rate of suicide among any age group, I wanted to look a little bit closer at this issue for this population. So like other age groups, suicide rates vary quite a bit by other demographic characteristics as well. So in particular, suicide rates are very, very high among men, and then very high among white people in the 75 and older age group. There's also some variation you can see on the right side by geographic region. Another distinguishing characteristic of suicide among older adults is suicide method. So for ages 75 and older, 76% of suicide deaths are by firearm. Among the overall populations, it's 53%. And this greater use of firearms is likely a major driver for the higher suicide rates that we're seeing in this population. This is because suicide attempts by firearm are much more lethal than other methods. So studies show firearm suicide attempts are 90% fatal versus under 10% fatal for drug overdose or poisoning attempts. Since the vast majority of people who attempt suicide and survive do not go to die by suicide at a later time, and the majority do not attempt suicide again, it really underscores the method of suicide is very important in determining suicide rates in the population and should be a key consideration in suicide prevention strategies for older adults. Next slide. Finally, I looked through research specifically on suicide among older adults to see if there were other notable findings to highlight for you all. Many of the risk and protective factors are similar to other populations. This includes risk factors like stressful life events, access to lethal means like firearms, and depression. And then also protective factors like family support and coping and adaptive behaviors are also similar across populations. One notable difference that I saw in research around risk among older adults was the type of stressful life events noted is pretty different from other ages. In particular, there was notes about life transitions being a critical moment of vulnerability, an increase in suicide risk for older adults. This includes things like retirement and medical diagnoses were both noted, as well as a particular emphasis on the death of one's spouse as a critical and vulnerable point of life. A second difference was the discussion of physical illness and dementia as risk factors, specifically in the older adult population. I included a number of studies that talk in depth about some of these risk factors and findings, and I added them to the notes of the slide. So if you are interested in looking more into some of these risk factors, I encourage you to take a look. And it's certainly important to consider these if you are thinking about prevention strategies. Next slide. And that's all from me. Thank you so much for their time. Happy to answer questions when we do that, or feel free to follow up by email at another time. And with that, I'll pass it over to Brandon to talk about our recommendations.
Thanks, Molly, and good afternoon, everyone. Next slide, please. So I'll just start with an overview of the recommendations from the report, and then I'll discuss how many of these recommendations can support older Americans specifically. And our recommendations, as you can see, fall under three categories here. First, investments in measures to prevent or mitigate adverse childhood experiences, or ACEs, like abuse and neglect, and to support prevention and early intervention programs in schools. Second, actions to reduce harms by lowering overdose risk and limiting access to lethal means of suicide. And finally, actions to transform our mental health and substance use prevention system more broadly, to expand and diversify the behavioral health workforce, and to integrate physical and mental health care. Next slide, please. I'll turn now to discuss some of the detailed recommendations in these areas, starting with measures to reduce ACEs and the impact of trauma. So we know that ACEs can have a long-term bearing on physical and mental health, but they are preventable through multi-sectoral efforts. And we recommend that Congress increase funding for the CDC's ACEs program, which researches and disseminates effective strategies to reduce and mitigate ACEs. Congress should also authorize additional ACEs research, which TFAH has worked with members of Congress to develop legislation for, which would provide a strong focus on equity and community factors. We also note in the report that although schools are an ideal location for prevention and early intervention services, they need additional resources to perform these functions. And specifically, schools need support to increase staff training and screening and responding to childhood trauma, social and emotional learning programs that can promote lifelong health, as well as culturally and linguistically appropriate mental health services and screenings. And Congress can assist here by increasing funding for the CDC's Division of Adolescent and School Health, which has a proven impact on reducing risky youth behaviors, as well as by supporting comprehensive mental health programs for college-age young people. Congress and HHS should also increase access to early prevention and family support programs and expand the pediatric behavioral health workforce. And Congress can also support state-level upstream efforts by establishing a set-aside for prevention and early intervention services within the Community Mental Health Services Block Grant that SAMHSA operates. Congress should also significantly increase funding for the CDC's suicide prevention programs, which can promote strategies to deter suicide risk by strengthening economic supports, promoting connectedness, which would address some of the isolation issues that Molly mentioned, creating protective environments, and teaching coping skills, among other measures. Congress should also promote policies and programs to address the social determinants of health, including through coordinating efforts at CDC. And I'll talk a bit later about some of the specific SDOH factors affecting older Americans. And finally, Congress and federal agencies should strengthen the capacity of the behavioral health system to address the impacts of climate change, including for populations of color specifically. Next slide, please. To strengthen harm reduction efforts in this next category, Congress should increase funding for comprehensive syringe services programs and remove barriers to purchasing these kinds of supplies with federal funds. The Office of National Drug Control Policy and SAMHSA should continue to provide technical assistance to states as they adopt model laws to ensure the effective establishment of these types of programs, as well as access to fentanyl testing strips in the naloxone. Policymakers should also limit access to lethal means of suicide through several measures, including efforts to promote the safe storage of medications and firearms through public education and legal measures, as well as restrictions on access to firearms for children, individuals in crisis, and those at risk of suicide. And policymakers can also create protocols for healthcare providers, counselors, and first responders on how to interact with patients and counsel families to create safe environments. We also talk about the need for state and federal officials to help reduce the availability of illicit opioids and unnecessary prescriptions, including for seniors, through responsible opioid prescribing practices that are informed by the CDC's guideline for prescribing opioids, as well as by support for prescription drug monitoring programs that can track opioid prescriptions at the individual level. Importantly, to address fentanyl, policymakers should also support programs that can target psychostimulant use that complement current opioid-focused policies, as we see increasing presence of fentanyl and cocaine and methamphetamine supplies. And Congress and federal programs should enable additional flexibility in those programs in terms of prevention grants that can allow states to address substances other than opioids based on local needs. And finally, in this category, we talk about the need to reduce harms from alcohol by reducing availability, by enforcing underage drinking laws, and by holding sellers and hosts liable for serving minors or over serving adults. Next slide, please. Finally, in the last category, the report includes recommendations for transforming the mental health and substance use prevention system more broadly. We talk about the need for Congress and SAMHSA to bolster the continuum of crisis intervention services, including the 988 Lifeline, by providing additional resources for mobile crisis response units, specialized services for high-risk populations, including seniors, and by incorporating paraprofessionals like peer support specialists into those crisis services. Congress should also support efforts to modernize mental health and substance use services by incentivizing the integration of behavioral and physical health care, expanding reimbursement for certain services under Medicare and Medicaid, and incorporating services into primary care and emergency department settings. Congress should also expand access to these services, including by fully enforcing the Mental Health Parity and Addiction Equity Act, by extending Medicaid coverage to incarcerated individuals to address the needs of that vulnerable population, and by increasing federal reimbursement for state spending on treatment. Congress can also address gaps in mental health utilization by helping states and local governments enhance their community healthcare workforces, including through trained peer support specialists, as I mentioned. And Congress can also help sustain progress on capacity and workforce issues by reauthorizing provisions of the Support for Patients and Communities Act, which has really been able to surge resources to states and localities since 2018. And finally, Congress should promote equity in mental health, including through workforce diversity and culturally and linguistically appropriate services, which can help reduce disparities in access and outcomes, and improve data reporting on these types of access and outcomes by race and ethnicity can also help address disparities. Next slide. So I'll turn now to how the recommendations in the report can improve behavioral health outcomes for older Americans specifically. And to begin here, I think it's helpful to just highlight a New York Times article from this summer on how the fentanyl crisis in Baltimore has devastated Black men in their 50s to 70s. The article notes that although this group makes up just 7% of the city's population, it accounts for nearly 30% of drug fatalities. And more broadly, Baltimore residents born between 1951 and 1970 have fatally overdosed at the highest rates in the city across racial and ethnic lines. The article also notes that, quote, Black men of that age in the city are more likely to die of overdoses than cancer or COVID at the height of the pandemic. Drugs are essentially tied with heart disease for their top killer, unquote. And moreover, at least 31 of the 50 addresses where people have fatally overdosed in Baltimore, most often since 2018, are advertised as senior housing complexes. And experts in the article and elsewhere have pointed to several factors for this trend, including the lack of safe and affordable housing options, a lack of targeted outreach and education efforts, social isolation, and the changing drug supply, especially the widespread presence of fentanyl. As Molly mentioned, I think Karan mentioned as well, aging bodies may also have a harder time processing narcotics, and doctors often fail to diagnose substance use disorder among this population. Next slide, please. So given this context on the challenges that can make older Americans particularly vulnerable to overdoses in Baltimore and elsewhere, I'll turn now to how some of the recommendations we propose in the Pain of the Nation report can improve behavioral outcomes for this population. And in fact, several recommendations would have a significant impact. For example, increased funding for CDC programs focused on social determinants of health could help states, localities, and tribes consider secure housing for older adults as part of a public health approach to substance use disorder. Integrating mental and physical health care would also increase the touch points for older Americans who need substance use disorder treatment, including medication like buprenorphine. Supporting best practices on training and supervision for peer support specialists and reducing barriers to certification and practice for that workforce would also help reduce social isolation and ensure behavioral health services are culturally and linguistically appropriate, especially for older adults of color. Expanding certain service programs would not only provide additional opportunities for outreach to seniors and connections to care, but it would also help reduce infectious diseases and, of course, overdoses. The funding for mobile crisis units that we propose could help expand crisis services to access isolated older Americans who might otherwise be unable to access care. additional support at SAMHSA for communities that are grappling with the behavioral health consequences of climate change could also benefit older Americans who are especially vulnerable to flooding and other natural disasters. And finally, increasing resources for the distribution of naloxone and fentanyl testing strips would help reduce overdoses among seniors who are unprepared for the presence of fentanyl and cocaine and methamphetamine supplies. Next slide. And with that, thank you for the opportunity to speak with you today, and I'm happy to answer any questions.
Wonderful. Thank you, Molly and Brandon. Really interesting and I think really important information. Karan, let's take that down and see if folks have any questions. Please feel free to open up your video and or raise your hand or just come on and ask a question. And I will, while folks are thinking, I've got a couple of questions, at least one for each of you. So Molly, first of all, for you, excuse me, is there any specific data on suicides that occur among the older adult population that compares what happens in the nursing home or assisted living community versus older adults living in the community?
That's a great question, Megan. The mortality data that I've seen don't have place of death, but I think I can look a little bit more into some of the other data sets that tend to have more information about mortality around that. But
Yeah.
I'm not, the data that I have been looking at do not, but it's possible that there is other ones, and I'm sure that there are differences with, particularly around access to lethal means and stuff would certainly be different.
Yeah, I appreciate that. I know that that access is certainly a key issue in when you're comparing the two environments. So Margaret had a similar question about suicide mortality between urban and rural settings. Do we have any data that compares urban versus rural?
We have urban and rural data. It's not, I don't know where it's available for specifically the older adult population. I can again look a little bit more into it, but rural places tend to have higher rates of suicide.
Yeah, I wonder if the National Rural Health Association also might have some of that information.
Yeah, I assume it would be the same for this group, but I don't have specific data points to point to.
Thank you. I appreciate that. So I'm wondering too, Brandon, thinking about the recommendations, and for TFAH, of course, we have a robust government relations team on which you serve that takes these recommendations to Congress and the administration. But for folks who are working in public health, they're public health practitioners who may not be able to advocate, right? They may have some restrictions on what they're able to do. How can they use these recommendations in their work to improve policy in this area?
Well, I think that these recommendations can be a roadmap in terms of applying for federal grants, for example, for knowing kind of what's on the horizon in terms of federal opportunities for improving behavioral health outcomes for older Americans, understanding what potential changes are coming in terms of Medicaid and Medicare reimbursement, which can affect practices at the clinical level. And also, I think that many of these recommendations are based on the latest research that we're receiving and that Molly and others are analyzing here at TFAH. And so I think that can provide a roadmap for changes in approaches, even at the local level. And I think, beyond that, in terms of some of the harm reduction measures, just understanding the dynamics that can present obstacles to effective public health approaches to reducing overdose is helpful, because in some cases, there are legislative obstacles to providing fentanyl testing strips, for example, or the community distribution of naloxone. And so understanding why we're seeing some of the results we have encountered in terms of the spikes in fentanyl-related overdoses can help inform public health approaches as well.
That's really helpful. And I would imagine that this information is also really important to share with partners who actually do that advocacy and take those recommendations, even at the state level, I would think could be super helpful.
Absolutely.
All right. Other questions? Molly,
Hi.
go ahead, Tara.
Oh, no, I have a quick question. So looking at the large gender differences in suicide completion, have you guys also looked at suicide attempts to kind of account for that large difference, since statistically women tend to choose more non-lethal suicide methods to account for that differences, but also to look at some of that public policy change and public health approach?
I haven't looked at much at the data I've seen around suicide attempts for older adults. Is I haven't seen very specific data. It's more like, I think I saw one that's like 45 and older or 50 and older. So it's not very specific. And I don't think it's by gender, but it's a really good point that as a whole, women tend to attempt suicide more, but do not choose as lethal methods and do not die by suicide as much. But men tend to do more likely to have a firearm and choose that. And since it's 90%, the studies have shown people who attempt suicide by firearm die 90% of the time. And that's just so much higher. And that's why I mentioned that it really is a driver, I think, of higher suicide rates in this population, because the method is, more than 3/4 of older adults who die, including most of those are men, die by firearm.
Thank you, Molly. So another question from Margaret. That I believe that traditional Medicare limits output behavioral health. So Medicare Advantage may be more generous. Is this correct? And if this is true, is that on our national policy agenda?
Well, I would say that certainly making changes to Medicare reimbursement for behavioral health services is at the center of the policy agenda and the policy debates that are occurring, especially on Capitol Hill. I know the Senate Finance Committee, especially, which has jurisdiction over Medicare, is talking about a whole range of efforts. One, to boost the services that are covered under Medicare, but also have incentives within Medicare to integrate physical and mental health care services. So I think that is really at the center of what Chairman Wyden of Oregon and other members are considering going forward.
Thanks, Brandon. Good questions. Keep them coming. Jane, go ahead.
I was just going to say, there has been, if any of you sign into the NRHA, the Rural Health Association, there has been an ongoing discussion this whole week about Medicare Advantage plans. It might be worth looking at those. Tend to promise and tend not to deliver. And I don't want to, I'm just re-saying what the article is saying. Might be worth a read based on that question about Medicare Advantage.
Yeah, and this is Margaret. I'll add to that too. I'm from a state that is largely rural, and Medicare Advantage programs not only have sometimes ghost provider networks, meaning they're on paper, but you can't get into them. But the other piece is that the networks are not very broad, and they often require older people to travel very long distances, which is very difficult for people who have some sort of physical disability. So it disadvantages people in the rural community where the rates, it's interesting, Molly, the rates are higher, it appears, in rural communities, but the access to treatment is much reduced, especially for older people.
Yeah, I agree. And with the payments that rural hospitals receive for Medicare Advantage, it's really causing a lot of concern there. Whereas Medicare, you open and visit, although there's still issues with access and availability of services in rural areas. But I just wanted to clarify that it's really worth a good read. It's been a whole week of it.
Thanks, Jane and Margaret. Other questions or comments? I did have one other question, Molly, for you. Does the report provide age group breakdowns per state, or is that just at the national level?
It's just at the national level. When you get into state level, in a good way, there isn't enough people a lot of times in specific categories, so you can't, it's really hard to get too specific. But if there is anyone who is in a particular state and would like me to look at any data, I'm happy to look at it. It also might be like, if you combine the last 5 years, you can get enough data to get something to look at, but a lot of times in 1 year, especially or if you're in California or Texas, you can probably do it. If you're in North Dakota, there just aren't enough people, because thankfully these events are still relatively rare. So there just isn't sufficient data. But again, if there is someone, I'm happy to, if you want to follow up, and I can think about what kind of data might be best available. Again, if it's a small state, it could be over 5 years, or if it's a bigger state, it could be a single year, but I'm happy to help out.
Thanks, I appreciate that. And Maddie, you had an interesting point. If you wouldn't mind coming on opening up your video and talking about the overdose death review board, because that's something that I certainly haven't heard about, but would love to hear a little bit more about that.
Absolutely. So I work for Michigan Public Health Institute now, but prior to that, I worked for a local health department in Ohio, and worked on a lot of different grant programs, older adult health, a lot of overdose prevention as well, healthy living, sort of along those lines. And so one of the main things that we were sort of ramping up on as I was working in the overdose prevention world was we were getting an overdose death review board up and running at the local level. And it's become very popular in recent years, similar to sort of like a infant mortality review board and along those lines. So we're coming up with a lot of best practices, but I think as we're learning more about overdose deaths and really looking into some of those details, I think a lot of the times the older adult population is really overlooked within this aspect and regard. And so I think that information and all of this data will be really helpful at that local level because of the common, not disregard, but overlooking of that older adult population. We might think of it as sort of that accidental overdose instead of intentional use. And so I think it'll be helpful for a lot of those who are working within that overdose prevention aspect of things to have that information and knowledge and sort of target some of their efforts in regard to the older adults.
Thanks, Maddie. Yeah, I know that that older adult health is overlooked in a lot of different ways. And so I think this one is really interesting, and appreciate your coming on and sharing that with us. Other thoughts, comments, questions?
Megan, it just reminds me of the very importance of this work, the very importance of course, I remember when TFAH was first a grantee of the foundation, of how important how well known you are for impacting the country through your reports and all the great reports that you do. And then Maddie talking about this, it just reminds me of how important the age-friendly public health system is, and these meetings and webinars, and just call out how I appreciate that. I also would say, do you track the use of the reports? I probably should know this, but do you track use and how people are going to use it, or people contact you for more information? How does that work?
I can address that, and then I welcome Molly's comments as well. But we use the report in my portfolio as the basis for our interactions with the Hill, with the administration. And many of these recommendations have also been folded into our blueprint for the next administration and the next Congress. And so we'll be tracking that over the next 4 years. But even on a shorter timeline, we pull recommendations from all of these reports inject that into our conversations with staffers and members. And then in many cases, we use it as the basis for developing legislation with staffers. And so we try to see that through to the end to be incorporated into larger vehicles like the Support Act, like appropriations bills. And I think a lot of the research that Molly analyzes for us also contributes to our appropriations advocacy there to justify increases in funding for certain CDC programs and others.
Great. Thanks, Brandon.
And I'll just add, I mean, we definitely track some stuff on like who, I don't do it, but someone else at TFAH, you know, tracks what's happening with who accesses it on our websites through social media output, how many, you know, interviews we have about topics. And I will say, I think there's a surprising number of people who do reach out with who are our partners, but not partners that we know we have, you know, that, you know, I have someone from states who do look, especially at some of our state data for a number of our reports and depend on that we might not actively work with. So a lot of times we've expanded the appendix this year, for example, in the report, because we've heard that another one of our reports that's really useful to have some of the state level data. And so it's a lot of work, but we also hear a lot from state partners that it's really useful. And so it's always good to hear if you put in work and then it is actually gets used.
Great. Thanks, Molly. All right. Any other questions or comments? This has been really helpful today. Thank you, Brandon and Molly, so much for coming on and joining us. I'm sure that there will be further discussion among this community as we move into next year and thinking about new policies and at the state and federal level. So, Karana, we'll turn back to you to close us out here.
Thank you, Megan, and thank you again, Molly and Brandon. Great topic, great conversation around some of the implications of this work. Just as a reminder, our next training will be in October, on October 17th. We will have a colleague from the YMCA actually. And to register for that, you can register under events on AFPHS.org. And if you are pursuing a champion designation, if you are trying to become an AFPHS champion, please snap the QR code here or navigate to the website listed as well to indicate that you have attended this training so that we can count that towards your 6 that are required to become a champion. If you're viewing this as a recording, please pause now and document that you have attended this training, and we want to make sure again that we get you recognized. And I'll give everyone just a few more seconds. Thank you all for attending today.
Thanks, everyone. Take care.
Thank you.
Megan, can you stay on for a minute? Just have a quick question, or